Hello, my name is Ann Parker, and I'm an assistant professor in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins. I'm also director of our Johns Hopkins Post-Acute COVID-19 Team, or JH-PACT program. And I'm really happy to be here today to talk with you about our JH-PACT experience in caring for patients who are experiencing persistent symptoms following COVID-19. I'll start today with a case presentation to provide some context around the typical cases that we're seeing in our clinic. I'll very briefly then touch on post-intensive care syndrome, or PICS, because this provided the framework when we were conceptualizing our program. I'll talk in more detail about the impact of the COVID-19 pandemic on recovery from acute illness. We'll then discuss what we know about post-acute sequelae of COVID-19, or PASC, also known as long COVID or post-COVID condition. And then I'll present our Johns Hopkins PACT program as one multidisciplinary model of care for these patients. So to begin with our case presentation, this is a 43-year-old man with diabetes and obesity. His COVID course begins in August of 2020 when he develops cough and shortness of breath. A week later, he tests positive for COVID-19, and because of progressive shortness of breath, he's admitted to the hospital. He's ultimately hospitalized for 2 weeks and in the ICU for the duration. He is quite sick with ARDS, or acute respiratory distress syndrome. He's intubated, placed in the prone position. He receives some COVID-specific therapies, including remdesivir, dexamethasone, and convalescent plasma. Ultimately, he's discharged directly home with remote patient monitoring for pulse oximetry and heart rate. 6 weeks after his illness onset and 1 month after discharge, he presents to our JH-PACT program. At this point in time, he's reporting shortness of breath and chest pain. He's also hoarse, and notably, he had already been evaluated by ENT, and a vocal cord granuloma was noted and presumed resultant from intubation. He was having hair loss. He was reporting dizziness on standing. He was also reporting brain fog. And at the time of his visit, he was still on sick leave from work. So let's briefly touch on post-intensive care syndrome, because this provided the context and framework for our clinic when we were conceptualizing this in March of 2020. So we know from decades of literature that patients who have been critically ill are at risk for developing impairments in mental health, including things like anxiety, PTSD symptoms, and depression symptoms, cognition, and physical impairments as well. And these can last for months to years after discharge from the hospital. We know as well that patients who are hospitalized, although not necessarily in the ICU, also have an acquired transient period of vulnerability after discharge, and they can have impairments in similar domains. A fifth of these patients will be readmitted within 30 days. And very importantly, often the reason for readmission differs from the reason for index hospitalization. This suggests that perhaps there's something about the hospitalization itself and associated experience that can affect outcomes for our patients. Very briefly, I'd like to touch on this landmark study by Dr. Harridge and her colleagues, which was published in 2003. And this focused on one-year outcomes in survivors of ARDS. I think this is important to mention because this sort of sets the stage for what we knew about survivors of critical illness before the COVID-19 pandemic. What Dr. Harridge and her colleagues demonstrated is that over the course of an ICU stay, patients lost nearly 20% of their body weight. Now, 12 months after discharge from the ICU, that weight was regained, but there was a loss of lean muscle that was replaced with fat. And so this is important in sort of understanding that there's a change in body composition that can have important functional implications. In the same study, at 12 months after discharge, Dr. Harridge and her colleagues demonstrated that patients with ARDS were performing at 66% of predicted on a 6-minute walk test as a measure of physical function, so substantially below what would be expected. And only half of these patients had returned to work at a year after discharge from the ICU. Now, patients came in with ARDS as a cause of respiratory failure. That's the reason that they were ultimately admitted to the ICU. And what we see is that over a year following discharge from the ICU, changes in pulmonary function were mild to moderate. Most commonly, the DLCO, or diffusing capacity, was the most affected. And you tend to see that there is gradual improvement over time. And so patients are coming in with acute respiratory failure, but when they leave the hospital, it's their neuromuscular and neuropsychological issues that often are more challenging in their recovery. And so how has the COVID-19 pandemic further impacted recovery from critical illness or acute illness in general? And I'd like to talk about each of the core PICS domains in turn. So when we think about physical function, patients who present with COVID-19 are often quite ill with ARDS and require care in the ICU. In this setting, they might require mechanical ventilation, often prolonged, and they might be placed in the prone position. Patients with COVID-19 might also be at risk for developing myopathy. All of these things can further complicate recovery from a physical standpoint. We also know from prior research that the duration of delirium in the ICU is associated with subsequent cognitive impairment after discharge. Patients presenting with ARDS are often exposed to longer and higher levels of sedation. This can further extend the duration of delirium, which in turn can affect cognitive outcomes. We also know that throughout the pandemic, our patients have been exposed to constant media coverage. They also have grief. A lot of our patients, unfortunately, have other loved ones who are sick, or in the worst case scenarios, they've lost loved ones to COVID-19. Our patients also have a fear of infecting others, and they have a fear of being reinfected with COVID. And so each of these things can further impact recovery from a mental health standpoint. Visitor restrictions in the hospital and social isolation in the community can further impact recovery from both a cognitive and mental health aspect. And then really importantly, limited access to essential rehabilitation services can affect recovery across each of these domains. And this is true in the hospital as well as in the community setting, where because of infection and prevention control measures, often our patients had limited access to things like physical therapy, occupational therapy, speech language pathology. So let's touch on what we know so far about post-acute sequelae of COVID-19. This was one of the larger studies conducted to date of over 700 patients. It was conducted in Italy. Now, noticeably, only about 10% of these patients required care in an ICU, with only 62 requiring mechanical ventilation. So this is largely a study of patients that did not require critical care. The median duration of follow-up in this study was 105 days after symptom onset. Half of patients had at least one symptom, most commonly fatigue or shortness of breath over the follow-up period. In terms of shortness of breath, about a third of patients reported substantial dyspnea. And if you think back to Dr. Harridge's article, we're also seeing here that the DLCO, or diffusing capacity, was the most common PFT abnormality in about 20% of patients. And this was very modestly decreased. About a third of patients reported substantial PTSD symptoms in this study. 16% of patients reported being no longer independent at the time of follow-up. Fatigue was also quite common, with 44% of patients reporting substantial fatigue. In terms of cognition, they used the MoCA to assess cognition in this study and found that only 2 of about 300 patients had abnormalities. However, I'll talk in a little bit more detail further into the presentation about some other ways to assess cognition in this patient population that are perhaps more sensitive in detecting impairment. Importantly, they only found 2 asymptomatic subsegmental PEs over the duration of follow-up. These were found after investigating sort of a disproportionately elevated D-dimer. And then less than 10% of patients had the following symptoms: palpitations, GI symptoms, headache, cough, persistent loss of taste and smell. This is a 6-month study conducted in China of over 1,700 patients. Only 10 patients required invasive mechanical ventilation, or ECMO. So again, this is largely a study of non-critically ill patients. 3/4 of patients had at least one persistent symptom. And similar to the prior study, one of the more common symptoms was fatigue or muscle weakness. Shortness of breath was also common, again, in about 1/4 of patients, and the DLCO was the most common abnormal PFT at follow-up. Anxiety and/or depression were reported in about 1/4 of patients. However, only 5% of patients reported more than slight depression or anxiety symptoms. The 6-minute walk distance was about 88% of predicted, so again, below normal. In this study, they assessed almost 400 patients with lower extremity ultrasound, and interestingly, did not find any new lower extremity venous thrombosis. Now, this study also compared patients with more respiratory needs, more needs for respiratory support. So patients requiring high flow nasal cannula, non-invasive ventilation, or invasive mechanical ventilation, compared to patients who required nasal cannula or no supplemental oxygen. And they found that patients in the former group had more shortness of breath, more decreased mobility, and greater anxiety and depression symptoms. And this is important because one of the things we really want to understand is how presentations for long COVID might differ for patients who are hospitalized versus non-hospitalized, who are in the ICU or do not require critical care. So we can really begin to understand those presentations, risk factors, and tailor our treatment appropriately. This slide represents a figure that was adapted from a review article in Nature Medicine. And I include this to sort of summarize what we know about PASC. And we tend to think of persistent symptoms as occurring at least more than 4 weeks after acute COVID illness. And you can see that symptoms really cross a number of organ systems. And we're really trying to understand at this point the prevalence of these symptoms, how they might be related, potential risk factors, et cetera. So I'd like to talk now in more detail about our JH-PACT program, again, as one potential model of a multidisciplinary approach to care of our patients with PASC. Our clinic was established on April 7th, 2020. It's a multidisciplinary clinic. Initially, we started as a telemedicine clinic only because at that point in time, all of our clinics were conducting virtual visits. We've since moved to a hybrid model where we're also seeing patients in person as well. And our clinic is a partnership between pulmonary and critical care medicine, physical medicine and rehabilitation, and Johns Hopkins Home Care. We have 2 components to our clinic. We have our ICU component, where we see patients who required at least 2 days in the intensive care unit, and our base component, which includes patients who were hospitalized but did not need critical care, patients who were never hospitalized as well, but have ongoing pulmonary and/or rehabilitation needs. One of the hallmarks of our program is our weekly multidisciplinary meetings, which is a fantastic opportunity for us to get together with our colleagues between pulmonary medicine, physical medicine and rehabilitation, which includes physiatry, physical therapy, rehabilitation psychology. We have a neuropsychologist who joins us as well as representatives from home care and our fantastic nursing team. So this is a really great opportunity for us to systematically review our patients and discuss their needs from a multidisciplinary standpoint. You can see represented here myself and Dr. Brigham, who was one of the co-founders of our pulmonary PACT program, and then Dr. Sue Kim and Dr. Azola, who are co-founders of the physical medicine and rehabilitation PACT program. This figure is taken from a protocol paper that focuses on a study evaluating how unmet needs after discharge for acute respiratory failure are associated with subsequent readmissions and mortality. And this is a great figure that really summarizes a potential framework for a multidisciplinary approach to care of patients recovering from critical illness or acute illness in general. And I'd like to walk through each of these aspects in turn and talk about how we have tried to incorporate this in the JH-PACT program, again, as one potential approach to care for these patients. We know that patients who are admitted to the ICU are at risk for polypharmacy. Medications can be started in the ICU and inappropriately continued into the ward setting or outpatient setting. A perfect example is something like Seroquel, which is sometimes started in the ICU and can be inadvertently continued on into the outpatient setting. We also know that sometimes medications are stopped on admission to the ICU for various reasons and potentially inadvertently never restarted. And so having a pharmacist as part of the PACT team has been absolutely essential. They're able to provide a chart, a medication review, a phone assessment with patients, and then communicate directly with the PACT providers through the electronic medical record or by phone call as needed to discuss patients' needs. We've also had our pharmacists assist in just tremendous ways in helping our patients access medications that are sometimes challenging for them to access. For example, helping patients troubleshoot insurance issues around anticoagulation medications. We know that patients who have been in the ICU, or even not necessarily in the ICU, but in the hospital with COVID-19, often require medical equipment at the time of discharge. This can include oxygen, it can include walkers or other facilitators for home use. And so having our Johns Hopkins home care team involved has just been absolutely fantastic. They also have had a remote patient monitoring program where they have been monitoring patients' pulse oximetry and heart rate. And so when we have patients in this program who have been seen in the PACT clinic, this has been invaluable information for us to help titrate oxygen needs and even wean patients off of oxygen from the home setting. Some of our patients with COVID-19 do require subspecialty medical care. And as a pulmonologist, one of the services that I provide is a very detailed evaluation to determine what patients might need in terms of further evaluation from a subspecialty standpoint. So our patients do not all require pulmonary function testing or ongoing imaging, but some do. And so when this is indicated, we can have that additional testing completed. We also have targeted referrals to other medical subspecialties where we've identified providers who have an interest, often from a research and clinical perspective, in further understanding and advancing care for these patients. We also have weekly radiology rounds with our fantastic chest radiologists who review complex imaging and really begin to understand some of the patterns that we're seeing in the COVID-19 population as they recover. We also are fortunate to have an interstitial lung disease expert join our team to provide some nuanced recommendations and updated understanding in the literature regarding management of some of our more pulmonary complex patients. Physical medicine and rehabilitation is an absolutely essential part of our program. Our patients who are in the PACT ICU program have both a pulmonary visit and a physiatry visit. Patients who are in our base program see pulmonary and or physiatry depending on their needs. Our physiatrists do a standardized functional assessment. We are also fortunate to have a pre-existing POTS clinic and have worked closely with Dr. Chung, the director of that clinic, for referrals for patients who meet criteria for POTS symptoms as well. And then our patients have access to essential rehabilitation services like physical therapy, occupational therapy, and speech language pathology through PM&R and our home care program as well. I'll also add that while we do not have a formal nutrition component to our program, this is a very important aspect often to care for our patients following ICU or following hospitalization or acute illness in general. And we're working to incorporate that aspect as well. Engaging patients in improving health habits is another important aspect of what we do with the JH PACT program. And I will say that a very important part of our program is coordination with primary care. And we've worked to coordinate very closely with our primary care colleagues at Johns Hopkins and beyond. Now, some post-COVID clinics have a different model where primary care is either directing the clinic or very much directly integrated within the clinic. And I think whatever the model is, it is just very important to be very conscious about engaging and working with our primary care colleagues. In terms of health habits, we also, of course, do a detailed history during their pulmonary visit. We are fortunate to have Dr. Galiat Satos, who is a part of our PACT program and also director and founder of the Smoking Cessation Clinic at Johns Hopkins. So that's been a tremendous resource as well. We have a community health worker who has also been really important in working with our patients for things like helping them connect with primary care providers. Some of our patients are presenting having really never interacted with primary care before, helping patients who are uninsured or underinsured access insurance resources, as well as job resources, because we see that for our patients, this is a constantly changing landscape where what they were able to do before in terms of work might not be what they're able to do now. As part of our program, we do a detailed phone cognitive assessment that was developed through work with Dr. Vandersdaal and Dr. O, as well as Dr. Leketsos at the Johns Hopkins Memory and Alzheimer's Treatment Center. And I'll talk more about that momentarily. When patients screen positive for cognitive needs, they are referred to neuropsychology, rehabilitation psychology, speech language pathology, and/or occupational therapy as indicated. We also do a detailed mental health screen, and we've incorporated these aspects of care because we realize that sometimes patients are sort of flying under the radar in terms of their cognitive and mental health needs. And we want to be able to intervene early to help them further in their recovery. I'll talk a little bit more about the development of the instruments that we employ for mental health screening, because really we base these on an NIH-funded ICU core outcome measurement set. Now, our instruments differ slightly from what's recommended in the core outcome measurement set, and this is because of cost and licensing issues. But whenever possible, we do recommend adherence to core outcome measures, and I'll talk more about that momentarily. When patients screen above threshold, or if they have any subjective reports of difficulty with coping, anxiety, depression, PTSD symptoms, we are fortunate to have a psychiatry liaison working with our program and rehabilitation psychology as a part of our program as well. So these are the standardized assessments that we have been using from really the beginning of our program. I'll emphasize that while we use the GAD-7 and PHQ-9 to assess for anxiety and depression symptoms respectively, ideally we would be using the Hospital Anxiety Depression Scale, which is a part of the core outcome measurement set for acute respiratory failure survivors that you can see referenced here in red below. However, because of licensing and cost issues, we have been unable to employ that at this time. So we have actually seen closer to about 600 patients in our PACT program so far, but these demographics remain relatively constant. We have a mean age of about 54 years. About half of our patients are male. About a third of our patients identify as white or Caucasian, a third as Black or African American, and about 5% as Asian. About a quarter of our patients identify as Hispanic or Latino. About a fifth require interpreter services, most commonly Spanish. And then about 13% of our patients remain uninsured or underinsured. So some key points from our early sort of findings from our program, our patients tend to be relatively young. We have a disproportionate representation of Black or African American and Hispanic or Latino patients, which unfortunately is really on par with what we've seen with the COVID-19 pandemic across the board, with these groups being disproportionately affected. Access to care is an issue. Patients, like I said, are presenting uninsured or underinsured and needing access to interpreter services. There have been a number of studies and reviews really trying to understand disparities and how we can begin to bridge the gap when it comes to COVID-19 care. And I think some of the take-homes are we need access to trained medical interpreters to be sure that we're providing optimal care to our patients. Community-paced training programs are fantastic to really be able to expand some of those interpreter services. We need to be sure that our patients have longitudinal access to care. So we need to be working with our primary care partners to be ensuring that our patients have insurance and access to the care that they need longitudinally as their PAC symptoms are, as their PASC symptoms are managed and other chronic medical conditions are addressed. And telehealth services have been an important aspect of care for our patients during the pandemic when we haven't been able to see them in person. They've also been an important aspect for patients who are essentially homebound. So having access to those services through expansion of waivers for telemedicine services across state lines, but also ensuring equity of access. So making sure that patients have access to wireless internet, smartphones, tablets, so that they're able to connect for those visits. I'd like to touch briefly on the work we've done with the Johns Hopkins Memory and Alzheimer's Treatment Center in terms of assessing cognitive outcomes for our patient population. So we do a detailed cognitive assessment for our patients prior to their initial clinic visit. And this is conducted in English and in Spanish as well. You can see here some of our very early preliminary findings from both our ICU patients and our base or non-ICU patients. And overall, what you see here is that there is a substantial burden of functional impairment and impairments in mental health in both of these groups. You can also see here each of the cognitive domains that are assessed as part of the cognitive outcomes assessment. And really, what this represents is that there is substantial impairment across multiple domains, and this is affecting both ICU patients and non-ICU PACT patients. So in summary, approximately 3 months after their acute illness, we're seeing that more than half of our patients have at least mild cognitive impairment, with almost all domains impaired. And this is occurring in both our severely ill COVID-19 patients and our patients who had initial mild or moderate illness. Impairments are greater in our ICU compared to our non-ICU patients. And we're also seeing substantial mental health impairments as well. So let's go back to our case presentation to kind of understand how care progresses for these patients. Our patient did undergo cognitive testing and scored abnormally across multiple domains. You can see here a table representation of an evaluation of dyspnea, as well as measures for mental health symptoms. And I like to include this because I think it shows that sometimes there is an association or trend between what we're seeing in terms of complex multifactorial symptoms like dyspnea or breathlessness and some of our mental health symptoms like depression, anxiety, and PTSD symptoms. And I present this not to suggest that the shortness of breath, for example, as a complex symptom is being driven by anxiety or depression, but more to demonstrate that these symptoms are in fact complex, multifactorial, and can sometimes create a bit of a feedback loop where patients who are having shortness of breath, perhaps because of ongoing inflammation in their lungs or reactive airways or fatigue or any number of reasons, might also have symptoms of anxiety or depression. And when patients feel short of breath, they might feel more anxious. And this can create a feedback loop that it's important that we address both the anxiety component, the breathlessness component, and thus the importance of the multidisciplinary approach to care for our patients. Our patient in this case did have an echocardiogram that showed some hypokinesis in the basilar region, a preserved ejection fraction. You can see here pulmonary function tests showing mild to moderate decreases in lung capacity and DLCO. And these tended to improve over time. And a follow-up CAT scan of the chest actually looked much improved from prior. Now, this patient, because of some echocardiogram abnormalities, was referred for further cardiac evaluation, including an MRI and an event monitor. I will say that this tends to be a minority of our patients, but we do find that some of our patients need that additional evaluation from a cardiac standpoint. Our patient had a follow-up evaluation with ENT, and the granuloma that was noted previously on his vocal cords was no longer visualized. He was evaluated by our PM&R colleagues and was started an outpatient physical therapy program and also referred to the POTS clinic. The patient continued to have speech-language pathology therapy for vocal cord dysfunction and cognitive impairment, and it was also being followed by our rehabilitation psychologist for low mood and cognitive impairment. And at the time of follow-up evaluation, he was back to work, but he was not at his baseline. He was still feeling limited physically and cognitively. And I think this is a good representation of a patient who really required multidisciplinary care that included subspecialty medical care, also access to some of our essential rehabilitation services, and really needed ongoing evaluation and tailoring of their services and evaluation as symptoms progressed and changed. So in summary, we know that adult survivors of acute illness, especially in the ICU and including our COVID-19 survivors, are at risk for impairments in mental, cognitive, and physical health. And we have a lot of work to do to really understand past. We need to understand many gaps in knowledge, including incidence, prevalence, natural history, risk factors. We need these rigorous prospective cohort studies to lay that epidemiological foundation so that we can begin to develop interventions to help advance care for our patients. We also need research occurring alongside clinical care. Our patients have immediate needs now. And so this is a great opportunity for us to engage our patients in clinical care, to understand and recognize patterns as we advance the field from a research perspective. A part of doing this, and really one of the first steps, is the development of a core outcome measurement set. And right now, the WHO has a working group that is developing a core outcome set using a Delphi process, and other groups, including the NIH and some of our physical medicine and rehabilitation colleagues, are also working on identifying those core outcomes for evaluation of symptoms in this patient population. And I can't stress enough how important it is to have a multidisciplinary perspective when approaching care for these patients who really have often complex multifactorial symptoms. For more information about our PACT program, you can visit our website. And these are our fantastic nurses who really form the core and backbone of our program. Our program has really been a tremendous team effort, and there are more people involved than I could possibly thank individually. But you can see here the breadth of services provided and programs involved. And we are very grateful to be a part of the CAIRO, or Critical and Acute Illness Recovery Organization, which is a collaborative network of groups and sites who have post-COVID and post-ICU follow-up programs. And I am very, very pleased to have joining me today both Dr. Tracy Vanderstal and Jennifer Zaney. Dr. Vanderstal is an assistant professor in the Department of Psychiatry at Johns Hopkins and a neuropsychologist who works with our PACT program and specifically on cognitive outcomes in COVID-19 survivors, and has tremendous expertise in this area. Jennifer Zaney is also one of our lead physical therapists in the PACT program, and she has extensive expertise in multiple relevant areas, including post-COVID rehabilitation, post-ICU rehabilitation, as well as POTS. So welcome, and we are very pleased to take your questions at this time. I think we have one question in the chat from Anil, it looks like. What proportion of patients in the JH-PACT clinic have POTS, ME, CSF phenotype versus a post-hospital or post-ICU syndrome phenotype? And so this is really a fantastic question. I think in terms of actual proportion of patients, it's a little tough to say. I wouldn't be able to give you those exact numbers, but I think you did hit the nail on the head that there does seem to be sort of a distinct phenotype among our patients who are with initial less severe illness, who are having prolonged symptoms that sometimes seem to fit some of the criteria for the other syndromes that you mentioned. Like I said, we are very fortunate to partner with the POTS clinic at Johns Hopkins that's directed by Dr. Tae Chung. And so for our patients who are potentially meeting criteria for POTS, we often do refer to the dedicated POTS clinic. We also, of course, have our physical medicine and rehabilitation colleagues, specifically Dr. Alba Azola, who works with us directly as one of our co-directors in the PACT program, who also has expertise in this area, and I know has seen numerous patients who potentially meet criteria for POTS, ME, or CFS. So I think a lot more to come in this realm, and I think this is where our prospective cohort studies can really help to tease out some of these distinct phenotypes and also give us a better idea of what proportion of patients along the initial spectrum of severity of illness are sort of manifesting with these types of persistent symptoms following their initial COVID illness. And specifically, if you have any questions about cognitive outcomes in this patient population, Dr. Vanderstal is a fantastic resource, and you have a unique opportunity to pick her brain at this time. And similarly, Jen Zaney has, like I said, a ton of expertise in seeing these folks from a PT perspective, and is coming to this with a background and understanding both ICU outcomes and also experience working with POTS patients. So really, I think her worlds have intersected here in the post-COVID realm. So it looks like Michelle is asking if this is being recorded, and it is. So you will be able to access this webinar via the archives as well, along with the other webinars in the September series. We have another question by Kelso. asking, how do you overcome the initial resistance of patients to start rehabilitation? And perhaps I will ask Jen if she has any thoughts specifically on this question.
That's a good question, because I guess by the time they get to me, they've overcome that a bit. So I kind of do wonder on the patients that I'm missing, if there is this resistance, which probably is multifactorial. I mean, I definitely still have patients who aren't really comfortable being in a therapy clinic yet. So whether that's an option to do things virtually or not. So I feel like I have sort of a biased group in that I'm more seeing the patients that actually get to me, but I do wonder how many patients that through the PAC clinic that are referred to therapy. I think I don't think we capture them all. So I think there is this group of patients that have access issues, probably more so than anything else. They might want to actually start therapy, but we found more issues with like insurance and just transportation and access as being a challenge, as well as just technology to even try to do things through telehealth. So yeah, I don't know that I have a great answer otherwise.
So I think those are all great points, Jen. And we do have a somewhat biased population, right? The folks who are showing up to our clinic, have some degree of motivation to even come in the first place. And so they're probably more likely to continue with rehabilitation services, perhaps than someone who isn't referred or seen in the clinic. I think one thing that has been eye-opening for me in participating in this multidisciplinary clinic is recognizing that with multiple transitions in care that our patients undergo, there are lots of opportunities for them to sort of fall through the cracks in terms of those transitions and access to rehabilitation services. So someone might be discharged from the hospital and then go to inpatient rehab, and then they're discharged home and recommended for home services. And then maybe they're recommended for continuation of outpatient PT, for example. But sometimes that transition doesn't happen for one of many reasons. Their insurance becomes a barrier and they don't have somebody help them work through that. Transportation becomes an issue. And I think one of the benefits that I've found in our clinic is that we have a touch point with those patients and we're asking specifically about ongoing rehabilitation. We're having physiatry evaluate them. And so there's an opportunity to kind of say, oh, wait, actually, yes, you do need additional services. And let's see if we can help support and help you get access to those services. So we have a question here from Catherine asking if we can speak to some of the challenges, variations, and outcomes for patients who are bariatric. This is a really fantastic question. I think, we have seen obesity as a risk factor for more severe initial COVID illness. And so I think we are seeing sort of a disproportionate representation perhaps of patients who are overweight and obese in the clinic, especially from the post-ICU perspective. I've recently started collaborating with our metabolic clinic here at Hopkins. And we are fortunate to have a colleague who both worked in our inpatient COVID units and also sees patients in the bariatric metabolic clinic. And so I'm looking forward to sort of future and ongoing collaborations with them to try to use this as an opportunity for tying our overweight and obese patients into longitudinal care, and specifically a multidisciplinary program that's focused on those health habits as well that are so important for their care. Jen, I don't know if you have any comments specifically from a PT perspective with our bariatric patients.
I'm not sure from the post-hospitalization standpoint. Obviously, in hospital, there's always the challenges just with the rehabilitation and ensuring you have adequate equipment and mobility assist devices and things along those lines to really begin therapy that we don't really run into as much on the outpatient world with this population. But it hasn't come up tremendously for me yet in the patients I'm seeing. But again, I'm probably seeing a more biased group, so I haven't had and we know those patients are there because they're definitely the ones getting pretty sick from COVID. So
Yeah, we have another question here from Sandra about using expiratory muscle strength training to improve respiratory function. What I can say is that when patients qualify, I have been referring them to pulmonary rehabilitation. Initially, there was some barrier to accessing pulmonary rehabilitation in terms of just infection prevention control measures and the lab not being fully up and running. But that has improved. I think there is a bit of a wait list at this time. Jen, I don't know if you have any other thoughts on that particular question too.
I think for the patients, especially I kind of see a lot of the patients falling into two groups. I think you do have that post ICU, patients who've been mechanically ventilated, who have significant weakness, including diaphragmatic muscle weakness, that could benefit potentially from like more of inspiratory, muscle training aspect from those pieces. More so probably than your other group that we tend to see, which are having more of like maybe not the critical illness, but more of the long COVID symptoms, potentially more of the fatigue dysautonomia symptoms. So I think it sort of depends on the patient population, but I think there is definitely a role for inspiratory, expiratory, for using those type of strength trainers in folks that have been on mechanical ventilation for a prolonged period of time.
Yeah, I think that's very true. We have a question here from Martha about SLP and asking if she could advocate for one service or program in her adult outpatient clinic for this population. What would we recommend? And Martha, I'm assuming you mean kind of under the SLP umbrella. And I think that one thing that stands out to me is the cognitive needs of these patients. I'll comment that certainly, our patients who have been mechanically ventilated can sometimes experience, and also our patients who are on high flow nasal cannula can experience complications from a vocal cord standpoint, dysphagia. But I do think one of the greatest needs and one of my most common reasons for referral to SLP is cognitive outcomes. And Tracy, I don't know if you have any other thoughts on that particular aspect of care.
Not particularly, other than our patients are really grateful to have SLPs who are trained and willing to give cognitive rehab interventions and provide those interventions. For many of our higher functioning patients, they struggle with returning to work or feeling like they are back to themselves cognitively and really able to sort of take on the roles that they used to have. So having those practical strategies, working those through and practicing them with their SLP provider is something that they repeatedly say that they're happy to engage in. And at least for the patients that I end up seeing and referring on to our SLPs, there's not much of a barrier with respect to interest and motivation because they find it really valuable.
Yeah, I think that's absolutely true. And I think our patients just aren't perhaps innately aware of the breadth of services that are offered by SLP. So I think they're very pleased to interact and to learn of those potential services that can help in their recovery. We have a question here from Erin about loss of taste and smell, and have we observed any beneficial treatment approaches? So this is a great question. And we have the benefit here of collaborating with one of our ENT colleagues, Dr. Nicholas Rowan, who had a research interest and a clinical interest in olfactory dysfunction before COVID and has really sort of taken the lead in understanding the post-COVID complications from an anosmia perspective. And so he has actually developed a very cool pamphlet that describes smell training, and it actually even has some specific information around how to using household materials or purchasing via Amazon, that kind of thing. Some specific scents that you can use for smell training. So we generally take the approach of sharing that information. And then if our patients have persistent difficulty with smell and or taste that goes beyond probably about 6 weeks after their initial illness, then we're referring to ENT for further evaluation. But I think that the smell training has really been interesting for me. I mean, just rehabilitation for the nose and for smell, it's just sort of fascinating. But that has been one of our approaches. So we have a question here about telemedicine and a suitable outcome for measuring functional outcomes, especially reflex cardiopulmonary fitness in patients post-COVID. So I think we're asking here about outcomes that can be assessed specifically via telemedicine and not in person. And I do wish that I had Dr. Uzzola, our physiatry colleague, here on the webinar with me today to answer this more directly. And I'm happy to provide you with some more information following the webinar. But I do know that they have been using things like the AMPAC that they're administering via telemedicine. And I think some additional measures as well that have been pretty readily distributed via telemedicine. Jen or Tracy, I don't know if you have any other specific thoughts about that assessment using telemedicine.
Yeah, so I have had to do a lot through telemedicine, especially in the beginning of the pandemic. And so if you're looking more trying to get an assessment of cardiovascular fitness or just endurance, two of the measures that I use a lot is either the 5-time sit to stand or a 30-second sit to stand test. The other one is because those are easy to do with your video. And the other one would be a 2-minute step test. Where you basically just have a march in place for 2 minutes. Some patients can't even do that. It's also very helpful if they have their own home pulse oximeter, so you can take readings with those measures. So I typically will use those two primarily as sort of quick assessments of function and just sort of for heart rate and SO2, SpO2 response, if they do have that ability to check that at home. As well as, Anne had mentioned the AMPAC. There's other measures that we will do more to get just an assessment of their overall function, but with the actual step test or sit to stand testing, you can get more of a sense of functionality and cardiovascular response.
And from a cognitive and sort of mental health perspective, we've been using the Quick Dementia Rating system. It's a questionnaire that we revised to ask patients about functional limitations related to cognitive changes and mood changes, as well as their ability to participate in instrumental activities of daily living and things around the home. And we found that captures a lot of the sort of functional consequences of the cognitive difficulties that we are objectively measuring on our cognitive screening measures, as well as our sort of more classic depression, anxiety, and trauma-related distress questionnaire. So it gives us a better sense of how those are playing out in patients' everyday life. Patients are able to follow along and complete them over the phone. And it gives us a bit more of an idea of what areas they're struggling in and where we might intervene and sort of think about areas that are of value to them that they'd like to target to improve in terms of their functioning.
Great. We have another question here about prolonged hospitalization and patients with impaired cognition and significant weakness or impairments. And this is from Desiree, who works with patients in an LTAC and often sends them on to rehabilitation or a skilled nursing facility, and finds it challenging to answer, when patients are asking how long until they get back to their baseline. And this is a tough question. I think the most common trajectory that I tend to see is gradual improvement over time, but the slope of that improvement varies drastically from patient to patient. And there are patients who we have been following for well over a year at this point and are sort of still on that recovery phase. I think it's also hard to say, there are sort of periods in patients' recovery where they seemingly plateau. And for some of our folks, they might be facing a new normal after their initial illness. And what we try to focus on is helping to adjust expectations and emphasize the importance of getting back to those activities that really bring some sense of reward, the things that they need and want to be able to do, And if for a period of time, we need to help them find ways to do those with assists or aids or some sort of adjustment in their schedule or their approach, then that's what we do. But continuing to encourage folks to really work towards getting back to those rewarding activities and those things that they enjoy doing. But happy to hear Jen and Tracy's thoughts on that too.
Yeah, I agree. You know, there's so much variability. It's really hard to tell a given patient what they may look like in 3 or 6 months. I know that, you know, some of our patients who end up in the ICU are our patients who quite often have other pre-existing health conditions that put them at risk for cognitive difficulties or mental health challenges that were never sort of clinically appreciated before their COVID illness. And so, you know, it's an opportunity for us to talk about healthy behavior change, things that they can do to help, you know, maintain good sleep, nutrition, getting physical exercise to the extent that they're able and are sort of permitted to do so by their medical providers, the sort of reframing aspects of health behaviors as they're moving forward, and encouraging them to think about how engaging in those will have broad downstream consequences and beneficial consequences in terms of their thinking, mood, and emotional functioning going forward. But it remains a real challenge.
Yeah, I like to remind my patients it's going to, you know, especially those patients who are more significantly involved, you know, that this is going to be more of a marathon than a sprint. I mean, this is, you know, it's a longer term thing. I try to have people look in longer term blocks, you know, how are you now compared to 3 months ago? And overall, I think people are getting better. Some people slower than others, so, you know, but if people look at, you know, kind of more in blocks, and there's a lot of up and down, it's not a straight line trajectory. That's sort of what I've seen with the population. So it is hard, only, you know, having some patients just seen now maybe a year, or you know, having not a long-term experience with this patient population. But in general, I think people, you know, are getting better over time, maybe not back to their baseline yet. And so we, you know, I find I do a lot of education around pacing, around prioritizing activities, especially like what's most meaningful and how to accomplish those things with maybe slight modifications and pacing and things along the way, you know, as they're going through the rehabilitation process.
Great. And I think we have two related questions in the chat that I'll try to answer quickly before we close. And they're both around monitoring pulse oximetry. I think from Nancy, in terms of how accurate the Apple Watch is, they seem to be fairly accurate. We try to compare the accuracy against our pulse oximeters in clinic, and generally they're pretty close. I think what I tell patients is, you know, if they're measuring serially over time, not to get too excited about those measurements that like very sporadically dip below 90 or something like that, that it may be just sort of a spurious value. And then in terms of trying to help patients kind of stop, you know, initially when patients are acutely ill with COVID, we're telling them to measure their pulse ox at home and, you know, to contact us if it's dropping. And as they improve and recover, it can be an adjustment to sort of stop focusing on some of those vital signs, including heart rate, pulse oximetry, and things like that. And so I think that's where, as a pulmonologist, I try to be helpful in saying, doing a very thorough evaluation, identifying things that we might need to look into more via pulmonary function testing or further imaging when that is indicated, and then trying to provide reassurance that patients don't, you know, once we've assessed those things thoroughly, that they don't need to focus specifically on those numbers, and they can pay more attention to their symptoms and how they're feeling and listening to their bodies in terms of engaging in more activity and increasing their exercise. Now, for our patients who are on home O2, we do ask them to monitor their pulse ox periodically, and that's allowed us to help them in terms of titrating their home oxygen. And sometimes we're able to help them wean off of their oxygen a bit more quickly in that setting as well. So I think we are a bit over time, but thank you all for such a great discussion and for joining us today. It's really fantastic to have an opportunity to answer questions and hear about what other folks are doing as well.